everyone, and welcome to a presentation on approach to chest X-ray. We'll start with talking about some basics and move on to talking about a search pattern you could use. Let's start by talking about study techniques and quality. AP and PA, or anterior to posterior and posterior to anterior, are two types of projection techniques used to obtain a basic chest film. Below are two diagrams that offer representation of each of these projection techniques. Notice that the distinction is made based on placement of the X-ray tube. On the left side, we see that the AP films are obtained as the X-ray tube positioned anterior to the patient sends X-rays through the patient anterior to posterior before hitting the detector. On the right side, we see that the PA films are obtained as the X-ray tube positioned posterior to the patient sends X-rays through the patient posterior to anterior before hitting the detector. Here we have two examples of chest X-rays you may notice look slightly different from each other. On the left we have an AP film and on the right we have a PA film. PA chest X-rays are generally preferred. However, since X-ray sources need to be placed posterior to the patient, they are difficult to perform on sicker and less mobile patients. The heart, an anterior structure within the chest, is magnified in the AP view. Keep in mind how the X-ray tube is placed closer to the heart and the heart further from the detector, which results in an exaggeration of the heart size. However, this technique has its uses. It can be performed on patients who are supine. As a result, lung volumes are generally lower. Lateral views are useful for assessing pathology immediately posterior to the heart and in the lung bases. They have higher sensitivities for identifying pleural effusions as costophrenic angles where fluid may collect are deepest posteriorly. The next main aspect of technique that plays a role in the quality of the image obtained is the idea of exposure. When obtaining a radiograph, the energy and amount of radiation used to generate the image needs to be balanced so that some is absorbed by the patient and some passes through the patient and hits the detector. As you can see in this diagram, although the quantity of radiation projected may be set at the level of the X-ray source, the amount of radiation that hits the detector is not always predictably similar. In a correctly exposed X-ray, there is an optimal balance of radiation absorbed by the patient and that which passes through the patient. Optimal exposure allows for optimal evaluation of the lung parenchyma, bones, and mediastinum. In an overexposed image, too large of a portion of the radiation passes through the patient. The lungs generally appear darker and as a result are tougher to evaluate. As an exercise, we can revisit our diagram of an individual getting an upright AP chest X-ray. In this example of an overexposed image, the X-rays pass through the patient with very little decrease in the amount of radiation that hits the X-ray detector due to absorption by the patient or scatter. On the other hand, in an underexposed image, too small of a portion of the radiation passes through the patient. Lungs appear brighter in this case, and yet are still tougher to evaluate. In this diagram now representing how an underexposed image may be obtained, radiation passes through the patient, but a relatively small amount of it reaches the detector. The next aspect of technique we'll discuss is the respiratory state in which the radiograph is obtained. If a radiograph were to be obtained during expiration, we may be concerned about lower lung volumes, which can obscure true pathology. Notice in this example of a radiograph obtained during expiratory phase, the lung volumes are lower, crowding of hilar structures is present, and we can also notice some areas of atelectasis. These, alongside a prominence of the pulmonary interstitium, can be mistaken for pathology such as pneumonia or pulmonary edema. Therefore, chest radiographs are ideally performed in full inspiration. Let's move on to talking about terms we can use to describe findings on X-rays. When a report refers to something as an opacity, it's referring to something that appears bright compared to the normal lung. In this example, we see an opacity in the middle of the left lung, which turned out to be a pneumonia. A lucency refers to something that appears dark compared to the normal lung. Notice these areas on the chest X-ray that appear dark compared to the rest of the lung architecture. When paired with the CT, we can confirm that these areas of hypodensity are indeed large pulmonary cysts. Alveolar opacities refer to disease processes primarily resulting in opacification of alveoli. Blood in alveolar hemorrhage, pus in pneumonia, water in the setting of edema or lung injury, and cancer cells may all cause alveolar opacities. Interstitial opacities occur when a disease process primarily results in opacification of the pulmonary interstitium. Pulmonary edema typically starts this way, and as pressure mounts, it can progress to produce both interstitial and alveolar opacities. Mixed opacities is a term that can be used to describe the presence of both interstitial and alveolar opacities. In this patient with COVID-19 pneumonia, notice the peripheral and basilar predominance, which on a report may be described as mixed opacities. A nodule is a discrete rounded opacity in the lung. Recall that an opacity is something that appears bright compared to the normal lung. It is important to note that a nodule greater than 3 centimeters in diameter is referred to as a mass. In our example with a patient's lateral film here, we see a nodule in this patient's lung, and in conjunction with their CT and the nodule's position relative to the minor and major fissure, we can be confident in calling this a right middle lobe nodule. Silhouettes are lines formed where tissues of very different densities border each other. Common interfaces in the chest that produce silhouettes are soft tissue bone, lung and heart, and lung and diaphragm. The example on the left side of a right middle lobe pneumonia is important because it demonstrates how an absence of expected silhouette may be concerning for pathology. Notice that the airspace opacification on the right middle lobe extends to the right heart border. Instead of having an air soft tissue interface, now there is a fluid from the pneumonia and soft tissue interface. Fluid and soft tissue are similar enough in attenuation that the apparent line between these structures disappears. Next, we'll move on to terms that can be used to describe findings on CT. Ground glass opacities on CT refer to an area where normal lung architecture is still visible through the pathology. On the other hand, consolidation refers to normal lung architecture not visible through opacity. These are tree and bud nodularities. They're multiple small and clustered nodules which are positioned along the bronchi. Recognizing these different patterns of opacification on CT is important because these influence your differential diagnoses. For example, typical pneumonia usually results in consolidation, whereas atypical pneumonia often presents with multifocal ground glass or tree and bud opacities. Let's conclude this presentation by talking about a search pattern you can use to navigate a chest X-ray. One search pattern that can be used for chest X-rays is the ABCDE approach. A for airway, B for breathing, C for circulation, D for disability, and E for everything else. Let's use a search pattern on an example case in front of us. Starting with airway, I would look at the trachea to see if it's stenosed or deviated. For breathing, I would be looking at the lungs and the pleural spaces. I'd be scanning for any opacities and assessing for symmetry. C for circulation, I would be looking at the cardiopericardial silhouette and looking if there's a widening of the mediastinum. D for disability, I would be looking for any bony pathology, not just limited to the ribs, but the spine, and if they're in view, the shoulders as well. E for everything else, I would be looking underneath the diaphragm, soft tissues laterally, and if it's in view, I would be looking at the neck. Now we can go through our search pattern step by step. As we perform the A for airway step, I'll be thinking about deviation or stenosis of the trachea. As I trace this trachea from the top of the image down to the carina, I've noticed that the trachea has deviated to the left, away from an abnormally appearing lung. This is an example of a space gaining process when the trachea moves away from the abnormally appearing lung. Examples of space gaining processes include pneumothorax, pleural effusion, and pulmonary mass. In this case, this was a tension hydrothorax. Similarly, as I examine the airway for this patient, I noticed that the trachea has deviated to the right towards the lung with multiple opacities. This is an example of a space-losing process in which the trachea moves towards the abnormally appearing lung, especially in the case of atelectasis. At the B for breathing step of the search pattern, I'm checking for lungs and pleural spaces for symmetry. I'm also looking for any abnormal opacities or lucencies. I'm also tracing the lung margins, looking for loss of normal silhouettes. On this patient, we found a right middle lobe nodule at this step. In this example, as we checked the lungs and pleural spaces for symmetry, we saw blunting of the cosophrenic angle and a meniscus, suggestive of a pleural effusion. At the C for circulation step of the search pattern, I'll be assessing for the size of the cardiopericardial silhouette. This is important because normally no more than 50% of the diameter of the thoracic cage on a PA chest X-ray should be occupied by the cardiopericardial silhouette. I'll also be looking for enlargement of the aortic arch or pulmonary arteries, and I'll be looking for widening of the superior mediastinum. In this example of a pericardial effusion, we clearly see that the cardiopericardial silhouette occupies more than 50% of the thoracic cage diameter. This is better demonstrated on CT to be a pericardial effusion, as the structure surrounding the heart is similar in density to fluid. Remember that what you see in the middle of the chest is not just the heart, it's the heart combined with the pericardium and central vasculature. Collectively, we refer to these structures as the cardiomediastinal or cardiopericardial silhouette. When you see what looks like enlargement of the heart, this could be a big heart or enlargement of surrounding structures like vessels or the pericardial space. At the D for disability step of the search pattern, we'll be looking at bony pathologies. We'll be evaluating the ribs, the spine, and shoulder girdles. In this example, we see a moth-eaten appearance of the left humerus, which was later confirmed to be an osteosarcoma. As we conclude with everything else, we look underneath the diaphragms, and in this patient we see free air concerning for pneumoperitoneum. We look for chest wall soft tissues, and in this patient we can clearly see right chest wall subcutaneous gas, and in the lower neck soft tissues. Lines and tubes remain a discussion for a different day.